Good afternoon and welcome to Webinar Wednesday. Today's webinar is on menopausal hormone therapy, best practice update with Dr. Doreen Saltiel. My name is Winter Kaiser and I'm a member of the Dutch Marketing and Education team, and I want to thank you all for taking the time to be with us today. A few housekeeping items before I introduce Dr. Saltiel. I've added the slides to the handout section so you can download them now if you wish. We'll try to answer some questions at the end of the webinar, and you can submit those in the question section on the side panel of your screen throughout the webinar, and I'll choose a few for Dr. Saltiel to answer at the end as time permits. Also, if you miss anything or if you have to drop off early, please don't worry. We'll send out the webinar replay and a link to the presentation slides tomorrow to the email you registered with. Please make sure you have sales@dutchtest.com saved to your email contacts and check your spam folder, as sometimes those emails get stuck in there. For anyone listening who might not have an account with us but would like to, please visit the link I've posted in the chat and complete the Become a Provider form. We have a great opening order offer for all new providers where you can receive up to 50% off to up to 5 test kits. If you're not familiar with Precision Analytical and the Dutch test, Dutch stands for Dried Urine Test for Comprehensive Hormones. We offer simple and convenient at-home collection for patients, and our advanced testing methods help providers answer the most complex clinical questions with the most reliable and trusted results. In addition, our customer service and in-house clinical consulting teams are always available to answer your questions. At this time, I'd like to introduce you to Dr. Doreen Saltiel, our presenter today. Dr. Saltiel practiced interventional cardiology and phlebology for over 20 years and is both an advanced fellow and board certified in anti-aging and regenerative medicine. She holds a medical degree from New York Medical College, completed her internal medicine residency at Brooke Army Medical Center in San Antonio, Texas, and a cardiology fellowship at Walter Reed Army Medical Center in Washington, D.C. She then practiced cardiovascular medicine for 14 years in the Army. Following more than 20 years as a board-certified interventional cardiologist, her functional medicine practice focuses on preventative cardiology and men and women's hormone health. So without further ado, please join me in welcoming Dr. Doreen Saltiel.
Thank you, Winter, for that very kind invitation. I thought today that we would just look at menopausal hormone therapy, looking at the evidence through the lens of a case study, because we all like to take care of patients, and it's important that we're able to apply what the evidence says to each of our individual patients. So, let me introduce you to Liz. She's a real patient. She's a 52-year-old postmenopausal female who seeks advice on menopausal hormone therapy. Her last cycle was approximately 18 months ago, and I'll pause here and say, by definition, menopause is defined as no cycle for 12 months. So she's actually, by definition, menopausal for only 6 months. And not surprisingly, she's miserable. She's got brain fog, hot flashes, night sweats, and she complains of vaginal dryness. She has no energy, feels anxious all the time, and her mind can't stop racing. She has trouble sleeping, and she wakes up multiple times during the night. She's happily married, has grown children, and in fact, she's expecting her first grandchild. She's a physician and has a very busy practice. She has a normal body weight, as you can see from the picture above, and a normal BMI. She states that she exercises regularly, primarily runs with some minimal strength training 7 days a week, twice a day. To me, she overexercises. She takes vitamin D, 5,000 international units a day, calcium, and multivitamin after a recent bone mineral density documented osteopenia. Her past medical history, family history, social history, and review of systems are otherwise unremarkable. And a recent mammogram was normal, as was a recent pap and pelvic exam. For all you clinicians out there, if you're going to prescribe hormones, you need to make sure that these tests are normal. If you're not the ordering practitioner, then you need to have the paper either electronically in your chart or in your hot little hands, because it's important that you document that a mammogram, a pap, and a pelvic exam were normal. Now let's look at her baseline labs. I highlighted some of the key factors. Number one, she's insulin resistant. Her fasting blood sugar is 90. Her fasting insulin is 8. Not terrible. 5 to 7 is where you really want it. And her hemoglobin A1C is climbing up there at 5.7. Surprisingly, her thyroid was normal, and when we look at her lipids, we see that her triglycerides are 120. I usually like them at less than 100, and her LDL particle number, which is a key prognostic indicator of a future event, was 1200, and this lab's normal is less than 1000. And so what that means is that she's got small, dense LDL particles that can actually get through that glycocalyx layer, that endothelium, and cause havoc in that subintimal space. Her ApoB is 95. You really want it less than 90, so that places her at moderate risk. But her HDL, her cleanup lipids, are 50, and they're large and buoyant, and they're like garbage trucks, and they can carry a lot of weight. But she's inflamed. Her CRP is 1.7, the goal is less than 1, and a coronary artery calcium scan was 25, noting she's got mild plaque, she's low risk, but she's got subclinical atherosclerotic disease, and her CIMT is 0.6, and the goal is less than 0.5. Her treadmill stress test was normal, and as you can see over here, her serum hormone binding globulin is low. Why is that? She has no hormones. Her DHEAS is on the lower side, gives you a hint into maybe she has some degree of HPA axis dysfunction. Her vitamin D is normal. She's on vitamin D. And just as a clinical pearl, for every 1,000 international units of vitamin D you give somebody, it's going to raise their vitamin D level by 10. Documented in the literature. So if somebody's vitamin D level is 20 and you give them 1,000, it's going to go to 30. And remember, test, don't guess. And as you look at her FSH, LH, and all her hormones, they're low. Now, another key point. In postmenopausal women, you want to measure all their hormones using an LC-MS assay. I don't care if you're doing serum or urine. You want to measure it using LC-MS. You always, regardless of whether they're premenopausal or postmenopausal, want to measure testosterone using an LC-MS assay. And if we take this to men, you always want to measure estradiol in men, same thing, using an LC-MS assay. It's much more sensitive at these lower ends of the reference range. And her prolactin is normal. So what are we thinking regarding the differential diagnosis in this 52-year-old female whose last menstrual period was 18 months ago? Well, she's a symptomatic postmenopausal woman with probable HPA axis dysfunction, low-ish DHEAS, and poor sleep hygiene. She's got osteopenia, she's got insulin resistance, she's got mild atherosclerosis, she's an over-exerciser, does minimal resistance training, and I will tell you that she probably has an elevated cortisol, which causes a permeable gut, right? Corticotropin-releasing hormone increases gut permeability, leading to metabolic endotoxemia, dysbiosis, more inflammation, and potentially adverse outcomes. So what factors do we consider when determining what treatment we want to offer this postmenopausal woman? And we have to meet the patient where they are. What are the patient's treatment goals? How do we monitor treatment? This is key to ensure that we're in the studied ranges that have been proven to be safe and effective. In other words, you need to use a test that either has outcome data with it or has been validated against the gold standard, and we'll talk about that a little more. So we also want to know what the literature tells us about menopausal hormone therapy dosing, delivery, testing, and clinical outcomes. Well, let's start with the guidelines, some of which I think we can all agree. that menopausal hormone therapy is the most effective treatment for vasomotor symptoms and what they call the genitourinary syndrome of menopause, which is vulvovaginal atrophy, and has been shown to prevent bone loss and fracture. I think we can agree that risks differ depending on the type, the dose, the duration, the route of administration, and maybe timing. Treatment should be individualized, that's a check, and using the best evidence to maximize the benefits and minimize the risks with periodic reevaluation and follow-up testing to evaluate the benefits and risks of either continuing or discontinuing hormone therapy. And I think we all can agree that young women who are recently menopausal, who don't have any contraindications, the benefits outweigh the risks. However, for women who initiate hormone therapy more than 10 or 20 years from menopause onset, or are older than 60, the benefit-risk ratio appears less favorable because of the greater absolute risk of coronary disease, stroke, venous disease, and dementia. I have a problem with this because this statement is based on the WHI data, which used Premarin, or conjugated equine estrogen, and Provera, or medroxyprogesterone, a progestin, which are no longer relevant. In fact, the guidelines tell us that oral micronized progesterone and vaginal micronized progesterone are better options, and transdermal estradiol may be preferred, is preferred, especially in certain high-risk populations. So I would rephrase that and say, prior to initiating menopausal hormone therapy in all women, especially in older women, you need to risk stratify them, assess their endometrial risk, their breast cancer risk, whether or not they're at risk for osteoporosis or fractures, their cardiovascular risk, and their cognitive risk. And you need to continue with ongoing surveillance. It shouldn't be one and done. You need to do follow-up testing. This is where individualized care comes in. Now, the tug of war between menopausal hormone therapy exists regarding benefits and potential risks. We all agree and know that estradiol improves vasomotor symptoms, vulvovaginal atrophy, prevents osteoporosis. The data on cognition is mixed. And then on the other side, we struggle with the potential risks: endometrial cancer, breast cancer, cardiovascular disease. And because I don't have 2 or 3 hours to talk about these in detail, I'm going to cut to the chase. Estradiol alone decreases breast cancer incidence and decreases breast cancer mortality. The data shows it decreases breast cancer mortality by up to 45%. It decreases cardiovascular mortality by up to 54%. And we know what to do with endometrial cancer risk. So there should be no worry about breast cancer and cardiovascular disease, and we'll talk more about that. Well, let's start with endometrial hyperplasia and endometrial cancer. And whenever you're talking about endometrial hyperplasia and endometrial cancer, one word should come to mind: progesterone. Progesterone is the star of the show. We know that whether you're giving oral or transdermal estradiol alone, you will get increases in endometrial hyperplasia and endometrial cancer risk in women with a uterus. And so oral micronized progesterone and vaginal micronized progesterone, are necessary to balance estradiol's proliferative effects on the endometrium. And here's what the studies tell us. Oral micronized progesterone, 200 milligrams and 100 milligrams protect the endometrium. Vaginal micronized progesterone, doses of 200, 100, and if you're going to use less than 100, you need to give it daily, protect the endometrium. And to date, there is limited data on transdermal, on the skin, progesterone and endometrial protection. I don't care what people tell you. I don't care what you read. And I'll show you that the data is limited. In women without a uterus, progesterone should still be given for its non-endometrial benefits and in particular bone health. It is estradiol's physiologic partner. All right, here are the studies. And the reason I underline the PEPI trial is because that is the largest randomized controlled trial with biopsy-proven documentation that 200 milligrams of oral progesterone given with this, at that time was conjugated equine estrogen, 0.625 milligrams a day, protects the endometrium. The largest study. The Moyer study basically said if you're going to use progesterone sequentially, you need to use it for at least 12 days to get any progestogenic effect. The Replenish study, which looked at 100 milligrams in combination with oral estradiol, that's Bijuva, which has been FDA approved, actually tells us this, that in women whose serum estradiol at baseline is less than 5, they're more apt to spot. In women whose baseline estradiol is greater than 10 to 15, they're more apt to have a proliferative endometrium. In other words, the importance of providing adequate progesterone to protect that endometrium. And then I just want to point you to the 3 studies that are commonly cited when we're talking about transdermal progesterone, and it's not ready for prime time. REN was a pilot study, and it showed no progestogenic effect on biopsy when transdermal progesterone was given. VASHIST was the longest study where they used transdermal progesterone, and they found that 32% of women developed endometrial proliferation. And Leonetti is the randomized 1-year controlled trial that documented endometrial protection. However, she herself stated that further studies need to be performed before she would recommend transdermal progesterone for endometrial protection. And since 2005, no further studies have been done. So even though they got different results, these 3 studies all say the same thing. Don't use transdermal progesterone to protect the endometrium. Well, what about vaginal progesterone? Well, it maximizes the desired uterine uptake, which is what you want, while minimizing potential adverse systemic effects like sleepiness that you get with oral progesterone when it gets metabolized in the liver and goes to allopregnanolone, which binds to the GABA receptor and helps with sleep. What is important is that you can achieve systemic luteal levels using vaginal micronized progesterone, and it can be monitored in serum. You probably don't need as much as you do oral progesterone because it doesn't undergo first pass hepatic metabolism. But what's very important is that you cannot monitor progesterone given vaginally in urine. Why is that? The vaginal mucosa does not have 5-alpha or beta reductase enzymes. So DHEA and vaginal progesterone, you won't see metabolites, so it'll underestimate systemic absorption. So just be aware of that if you're using vaginal progesterone. Here are 2 vaginal progesterone studies. One was done in 81. This is 25 milligrams, 50 milligrams, and 100 milligrams, and they all peaked within 2 to 3 hours, and the 100 milligram dose reached 50% maximum concentration later than the lower doses, but at 24 hours, they both were down below luteal levels. What Corletta did conclude is vaginal progesterone could reach similar serum levels to that reached in the ovulatory and luteal phases. Confirming Corletta's study was the Nahul study in 93, which documented this is vaginal progesterone, this is oral progesterone, is that it peaks within 6 hours, it is maintained at 24 hours at these high levels, and then at 48 hours, it comes back down below luteal levels, but not below baseline. And Nahul stated that the vaginal route for progesterone was better for hormone delivery than oral progesterone. So let's talk about some clinical pearls. Estradiol increases endometrial cancer. Oral and vaginal micronized progesterone protect the endometrium. Don't use transdermal progesterone. But key, no lab test shy of an endometrial biopsy ensures endometrial protection, right? Doesn't matter if you're using serum, urine, and if you happen to be a saliva user, which we'll talk about, it's not going to tell you about the state of the endometrium. Follow the clinical data. All right, so now what about breast cancer and estrogen? Well, here's the bottom line. Any association between hormone therapy and breast cancer is rare. This association between hormone therapy and breast cancer is no greater than any other medications commonly used in practice. No greater than ACE inhibitors, no greater than beta blockers. So all of this hype about breast cancer and menopausal hormone therapy came about because of the WHI study, which, by the way, was not a breast cancer study. It was a cardiovascular disease study. So it shouldn't even be assessing breast cancer. But here's the data on the WHI. CEE alone versus placebo, after 20 follow-up years, decreased both breast cancer incidence and mortality, 45% breast cancer mortality reduction. While CEE and MPA statistically significantly decreased mortality only. Why didn't it decrease incidence? The reason is that the WHI falsely reported a higher breast cancer incidence when in fact there was an unusually low breast cancer incidence in the placebo arm. In reality, there was a null effect on breast cancer incidence. And let me show you what I'm talking about. Let's look over here on the left. These are women who had never received hormone therapy. They were randomized to CEE and MPA or placebo. And what you see is that the curves, the hazard ratio curves on breast cancer incidence were essentially identical. Nobody's going to argue. Now let's come over to this side. These are women who previously used hormones. There was a washout period. They were then randomized to CEE and MPA or placebo. And look what happens here. The curves diverge at 2.5 years. If you lift this curve up and place it right over this curve, it turns out to be exactly the same. So what happened here? Well, this placebo group had a lower breast cancer incidence than any of the other placebo groups in any of the WHI studies, still unexplained. And regardless of knowing this fact, the WHI authors continue to carry on that breast cancer incidence is increased, when in fact it has a null effect. Now, what about therapies that we commonly use? We don't use CEE. We use basically transdermal patches and gels. And what McCullough documented in the large Finnish database was that there was a statistically significant decreased breast cancer mortality up to 54%. What is really important is even when hormone therapy was used for more than 10 years, mortality reduction was greatest at 5 to 10 years. The earlier you start, the greater the benefit. And equally important is age at initiation was not related to breast cancer mortality, again negating that greater than 60 and greater than 10 years. But consistent with all the data, estradiol alone had the greatest mortality reduction. What about oral micronized progesterone when it's added to transdermal estradiol? It does not increase breast cancer. It either has a null effect or it decreases breast cancer risk, even when treatment is continued for greater than 10 years. And there are the studies down there. Now, I would be remiss if I didn't talk about the two studies which are cited regarding increased breast cancer incidence. That's the Million Women study and the E3N study. Both had design and analytical flaws, so I ask you to look at them cautiously. The Million Women study, a third of the women used more than one regimen. And similar to the WHI, the control group had a lower breast cancer mortality than the general population. Breast cancer was diagnosed 1.2 years after recruitment. And what we know is that it takes approximately 10 years for breast cancer cells to become clinically evident, which means that these women probably had underlying breast cancer when they were randomized. What about the E3N study? Overall, estradiol, they use transdermal estrogens predominantly, and oral micronized progesterone had no increased breast cancer risk. But E2 alone did increase breast cancer risk. And that if you used estrogen for more than 5 years, you may have a persistently increased risk even years after you stop using the drug. Well, what's this about? Estradiol alone group, 72% used the progestin. In the E2 and OMP group, 57% used the progestin. So both of these studies, the data is not clean. So I wouldn't use these studies, and I confidently can tell you that estradiol does not increase breast cancer in an appropriate patient. Okay. So we've seen that you need to balance estradiol's proliferative effects with oral micronized progesterone and vaginal micronized progesterone. Now we've learned that estradiol decreases breast cancer mortality and breast cancer incidence, and that adding oral micronized progesterone or vaginal micronized progesterone doesn't increase the breast cancer risk. So using transdermal estrogens and oral micronized progesterone or vaginal micronized progesterone are safe for the breast and safe for the endometrium. And then there are just some key points that we've talked about. Don't use estradiol in a woman with a uterus unopposed. We know that estradiol alone decreases breast cancer and breast cancer mortality. When adding oral or vaginal micronized progesterone, you can be assured it does not increase breast cancer incidence, and decisions regarding initiation and continuation, regardless of age, but especially in women greater than 60 or greater than 10 years, should be individualized. In all women, risk stratification and surveillance should be an ongoing process, which includes follow-up testing. Don't just test once, start hormones, and never test again. It is very, very important. Women's detoxification profiles change. Women's estrogen metabolism, as well as men's, don't forget about men, their profiles change. Assess methylation activity. Look at cortisol. Don't be one and done. To have a successful hormone practice, follow-up testing is absolutely necessary. Now, we still haven't answered all the questions. We know that menopausal hormone therapy is safe for the breast and safe for the endometrium as long as you use progesterone. But what does the literature tell us about estradiol, progesterone, and testosterone in clinical outcomes? What doses and delivery methods improve outcomes? And what serum and/or urine levels have been documented to improve clinical outcomes? Well, let's chat a little bit about that. Transdermal estradiol, oral or vaginal progesterone, and transdermal vaginal pellet testosterone therapies improve symptoms and clinical outcomes. I'm not going to read all this to you. We just went over this, but in general, transdermal estradiol, especially patches, improve vasomotor symptoms, vulvovaginal atrophy, bone mineral density, sexual function, cardiovascular outcome, cognition's mixed, and they decrease breast cancer mortality. Progesterone is estradiole's physiologic partner. It's necessary to balance estradiol's proliferative effects on the endometrium, and it's very, very important in maintaining bone mineral density. It will improve vasomotor symptoms. You'll need a higher dose than 100 milligrams. The studies were done with 300 milligrams, and it may take longer. Testosterone, when added to estradiol and progesterone, improves bone mineral density to a greater extent than estradiol and progesterone alone. We know it improves sexual function. It does improve vasomotor symptoms and vulvovaginal atrophy, and it may be due to the aromatization to estradiol. And it does not increase breast cancer, endometrial cancer, or cardiovascular disease. And again, I'm going to stress this over and over again with testosterone, initial, as I do with estradiol and progesterone. Initial and ongoing risk stratification with follow-up testing is a must in all women. So what do we know about transdermal estradiol? Well, the literature tells us that all FDA-approved patches improve clinical outcomes at serum levels of 20 to 40 picograms per mil, and in the studies you saw symptomatic improvement at 4 weeks. Now, don't take 4 weeks to the bank, because a lot of women, it takes up to 12 weeks to maximally improve all of their symptoms. FDA-approved gels improve vasomotor symptoms and vulvovaginal atrophy, but they're not approved for osteoporosis. Why is that? Because whenever you're going to test a drug for FDA approval, it's compared to what is the standard, and in this case, it was patches. And it either has to be equivalent to a patch or better than a patch. And when it was compared to patches, gels require higher doses and higher serum E2 levels to achieve bone protection. So it never received FDA approval. And something that may come to a surprise to many of you, there is no data on the efficacy of compounded creams. I'll pause. There is no data on the efficacy of compounded creams. Yes, I use them. I document why I'm using it versus a patch, and I explain to the patients that there's no data. We need to follow them closely. And as I said above, a serum E2 level of 20 to 40 picograms per mil, or a 4-spot dried urine level of 0.07 to 1.8 nanograms per milligram is the sweet spot, and that should be 0.7, not 0.07, for most women. Did I say urine? Yeah, I did say urine. Now, serum testing is the gold standard. Before you use another test and you leave serum testing, it has to be validated against the gold standard. Either it itself needs to have been in clinical studies documented to improve clinical outcomes, or it needed to be validated against the gold standard. And the Dutch test it is a validated urine test against the gold standard serum. It was tested against dried urine versus serum and dried urine versus liquid urine. And what they found was that for estradiol and progesterone, the dry urine assay is a good surrogate for serum testing. It is statistically equivalent to serum testing. So what that means is you can monitor, and I will tell you it's probably a better monitoring tool than serum, because you get over 24 hours as opposed to one point in time. And serum levels go up and down. And because liquid urine, when you're talking about urine, is the gold standard, it was comparable to liquid urine. But a recent study tells us that maybe in recently postmenopausal women who have subclinical atherosclerotic disease, they may need higher levels. They may need to be above that 0.7 to 1.8. The ELITE study, which looked at postmenopausal women using 1 milligram of oral estradiol, and they used vaginal progesterone, 45 milligrams, and they tested these doses in what they called early menopausal women less than 6 years, or later menopausal women greater than 10 years, and the average was 14 years postmenopausal, and these women on average were 63 years old, and they had subclinical coronary disease. To minimize CIMT progression, these women early postmenopause needed a serum level of about 48. So it's above that 1.8 or at that 1.8 and over 40. But again, you need to risk stratify the patient. If you have a young woman with no cardiovascular risk factors, no subclinical atherosclerosis, you can keep her at 20 to 40. Some women may require higher for symptomatic relief. But in general, that 20 to 40 and that 0.7 to 1.8 are your reference points. However, what this same study showed is that in older postmenopausal women, a higher serum level statistically significantly increased CIMT progression. The mean was about 40. So I would say keep them less than 40, 20 to less than 40, and urine levels of 0.7 to less than 1.8, about 1.5 and about 30. You know, everybody's an individual. But what you need to remember in recently menopausal women and in older postmenopausal women, it's not just about hormones and it's not just about estradiol levels. It's one of many factors. What does their HPA axis look like? What is their inflammatory burden? And so you need to take the entire patient into account when determining what dose, what hormone levels to shoot for. And when we're talking about delivery systems, the 0.014 patch is no longer available, so the typical starting dose on a patch is 0.025 milligrams. Interestingly, the FDA study showed that if you place the patch on the butt, what happens is you get higher serum levels, i.e. increased absorption. If you're going to use a cream, it needs to be compounded. In older women, the typical ratios are E380, E220, and in younger postmenopausal women, 50-50. Starting doses are anywhere from 0.25 to 0.5 milligrams a day. And again, there are no outcome studies. Start low, go slow, test, don't guess. And gels are product specific, and again, they're not FDA approved for osteoporosis. Well, what about pellets? I'm a pelleter, and I'm telling you, it's not a good option for estradiol delivery, period. Even in a woman who's had a hysterectomy, I start with a patch or a cream or a gel, understand their detoxification patterns, understand their estrogen metabolism, understand their HPA access before I would ever consider an estradiol pellet. And remember, in women with a uterus, 100 or 200 milligrams orally, or 100 to 200 milligrams, and you probably can use it 3 to 5 times a week, or 45 milligrams daily. And don't forget that after 12 treatment weeks, urine for comprehensiveness and blood for CBC, CMP, you want to get a serum hormone binding globulin, you want to get a total testosterone, because you're going to give them testosterone, and an FSH and LH. You want to see what your hormones have done. You want to make sure that your hormones are effective. FSH should come down, LH should come down. It's not going to come down to low, but it should drop 50%. And so again, clinical pearls, we just talked about this. All FDA approved patches improve outcomes. Data on cognition is mixed. Gels improve outcomes, not approved for bone mineral density, and no outcome studies on the efficacy of compounded creams. Now, serum, another clinical pearl, the gold standard, and Dutch, a validated urine test should be used for transdermal estradiol monitoring. Why do I prefer Dutch? Because in addition to hormone levels, you get metabolomics. including estradiol, cortisol, DHEA, and testosterone. This offers you a lens into what the tissues are seeing, in addition to inflammation and detoxification. All of these are key components to optimizing hormone health. You cannot just do a serum test, call it good, and expect patients to optimally receive good hormone care. There's no studies validating saliva's efficacy for menopausal hormone therapy monitoring. There is not a clinical outcome study using saliva itself, and there are no studies when you compare saliva to serum validating its efficacy. Once again, start low, go slow, proceed with follow-up testing to ensure you're maximizing the benefits and minimizing the risks. Well, what about testosterone in women? Not a topic that's talked about a lot. So what are the clinical outcomes? What does the literature say? It doesn't say much. More studies are needed to assess T-dose, delivery, serum levels, again, LCM, SMS, and clinical outcomes. Do I think they're going to be done? No. Testosterone therapy in women is either prescribed off-label or it's compounded. And there is no consensus regarding guidelines on testosterone therapy in women. And there's no uniformity in the studies guiding the dose, the testing, treatment goals, and outcomes. Well, similar to what we did with estradiol, let's start with the most recent position statement. And what the statement says is that the only evidence-based indication for testosterone therapy is hypoactive sexual desire disorder. I disagree. Testosterone in women should be measured using LCM-SMS. I agree. Measure total testosterone. There's less data on free or bioavailable. True. And there's an uncertain association between androgen levels, in other words, your testosterone levels, and what you see clinically. So women could have high normal testosterone levels and still have symptoms. And in fact, there's no cutoff level that can be used to differentiate those with and without symptoms. But they say if you're prescribing T, the goal should be to approximate physiologic testosterone concentrations, when in the physiologic range, there are no adverse effects. That's probably true. But I say, you just said androgen levels don't reflect or correlate with clinical findings. So how do you rationalize this? And there are studies documenting clinical effectiveness without side effects with serum levels at or above the reference range. And so here's the bottom line. Testosterone is safe, it's effective, doesn't increase cardiovascular disease, breast cancer, or endometrial cancer risk. And most of the studies that were done document that serum total testosterone levels at the high end of the reference range are needed for improved clinical outcomes. Patches aren't available, but look at the gel doses if you're compounding and the cream doses that we used in these studies, and there were no significant adverse events. T pellets, 50 to 100 milligrams every 3 to 4 months. And there are studies documenting clinical success when T levels are somewhat or many times higher than the upper limits of normal without adverse significant events. And this data is primarily from Becky Glazer, who's got the largest pellet database. And she's published in peer-reviewed literature that these women, though serum levels are high, have no adverse events. However, there are some small studies out there that you need to be aware of that do suggest that supraphysiologic levels are associated with metabolic dysregulation. I can tell you about my own experience of pelleting people, women, men, for greater than 12 years. I have never seen with T levels in women above the upper limits of normal of the reference range cause metabolic dysregulation. Never, ever, ever. And I've pelleted thousands of women. And so what are your options for testosterone? Well, if you're going to use a compounded cream topically, non-vaginally, Typical starting dose is 0.5 to 2. Can start it with testosterone, with estradiol and progesterone, and it will increase the bone mineral protection, as we've seen. If you're going to use vaginal testosterone, the lower 1/3 of the vagina or the labia. Now remember, the vagina is a mucosa. The labia is somewhere in between the skin, which is a barrier, and a mucosa. So just be aware when it comes to dosing where you're applying your vaginal hormones. And again, the most common starting doses are 0.5 to 1. And in women, pellets are an excellent option, but even so, understand hormone metabolism and detoxification. Don't start with a pellet. Start with a topical application. And once you understand how the patient detoxifies, how they metabolize hormones, then you may in time switch, if you're comfortable, to a pellet. Remember, the dosing is 50 to 150. The most common are 75 to 125, and the average is 100. But what you need to remember is patients require less than you think. If patients have no hormones and you give them some hormone, they're going to get better. The issue becomes when you're doing maintenance hormone therapy and they think they should get that same wow when, for example, you're doing maintenance pellet therapy. That doesn't happen. They've already reached that wow. You're trying to maintain them at a reasonable, level, asymptomatic, and patients will come and say, I need more hormone. No, they don't. No, they don't. They like that initial, oh, I feel up here, in the penthouse, when things average out, they're more like on the 8th floor. And remember, similar to estradiol, monitor hormone therapy and do urine for comprehensiveness. And again, more clinical pearls. Serum is the default. Urine adds comprehensiveness, which I'll get to in a second. Serum levels don't necessarily reflect clinical success, and for improved clinical outcomes, T levels should be at the high end of the reference range, and yes, unless using pellets where they're typically above. So putting this all together, a transdermal estradiol patch with oral micronized progesterone or 200 milligrams does all the things you want it to do. A patch with vaginal micronized progesterone does all the things you want it to do. Gels are a reasonable alternative. Doses are product specific. Testosterone therapy added to E2 and either oral or vaginal progesterone is safe and effective. It improves clinical outcomes. Again, ongoing follow-up testing, and appropriate surveillance is a must. So now we get back to Liz. As you remember, she's got typical symptoms. She has trouble sleeping. She's got osteopenia. Here, and again, you remember her baseline labs. She's inflamed. She's got moderate risk cardiovascular markers. So she's got subclinical atherosclerotic disease. She's insulin resistant, and she has no hormones. And when we put it all together, here's her summary. There are her symptoms. There are the tests we got. What additional tests are we going to do to assess her need, or what doses we're going to give her for hormones and assess her HPA axis? Well, we're going to do a Dutch complete where we'll look at urine, diurnal cortisol and metabolites. We'll look at all her hormones, and don't forget about the gut. We think she has some degree of dysbiosis with some degree of endotoxemia. Remember, you don't want hormones recirculating. Men and women need to move their bowels twice a day to get rid of those excess toxins and excess estrogens. All right, so similar to what we talked about with estradiol, saliva testing has become known as the gold standard for HPA axis or cortisol testing. And again, we have to ask ourselves, has the test, if we're going to leave saliva, been validated against the gold standard? And the answer is yes. This was published by Precision Analytical in 2020. It looked at salivary and urine diurnal cortisol measurements on the same day. Let me orient you. This is urine. This is saliva. This is a CAR, cortisol awakening response. And so if you want to know about resiliency, you can only get it in saliva. This is not a CAR. This first point is everything that was in Liz's bladder or a person's bladder during the night and at the first morning void. This is a few hours later. So the CAR is included in here, but this is not a CAR. This point gives you a lot of information. And what they found, it's a good alternative to liquid urine, and it's a good surrogate. It's statistically equivalent to saliva. Now let's go to Liz. Here's her first point. So what does this tell you? Let me orient you. This is the upper limits. This is the lower limits, and here's your within the reference range. All right, this tells you this high morning cortisol is that she didn't sleep well. We're not surprised. It's consistent with her history, and her cortisol was elevated during the night, and it stayed high, and it comes down, and it's flattened, and this elevated nighttime cortisol and flattened curve are associated with increased coronary artery calcium and increased cardiovascular mortality. Now we look at her 24-hour free cortisol and her metabolized cortisol. And metabolized cortisol is total cortisol production. You see she's got high free cortisol and she's making a lot of cortisol. So when you look at her metabolites and look to see whether they favor cortisol or cortisone, it shouldn't be surprising that they favor cortisone, right? She's making a lot of cortisol. She's got high free cortisol. The body tries to maintain homeostasis. It is trying to deactivate that cortisol. So it's shifting it to cortisone. In addition, it's trying to protect the mineralocorticoid receptor from all that cortisol. So this is classic. This is not surprising. Let's look at her estrogen metabolism. And you can say, Doreen, why did you do estrogen metabolism on somebody who has no hormones? Follow the trends, right? You see that her estrone, her estradiol, and her estriol are all low. Let me orient you. The purple band is the postmenopausal range. Here is essentially the follicular sort of range. And between the stars is your luteal range. And what you see is that all of them, not surprisingly, she has no hormones, is in the postmenopausal range. And then let's see how she's metabolizing hardly any of these hormones. And what you see, if we look at this nice pie chart, the expected ranges for 2-hydroxy, 4-hydroxy, and 16-hydroxy are down here. And you see that her 2-hydroxy, she's metabolizing down that 1A1 pathway nicely. However, she is predominantly going down that 1B1 pathway instead of the CYP3A4. And it's this 4-hydroxy pathway that increases DNA adducts, DNA damage, and potentially can increase the risk of breast cancer. They have found that in women with breast cancer, they are more prone to have elevated 4-hydroxy with less methylation. Those women who are less apt to get breast cancer favor the 2-hydroxy pathway with more 2-methoxy activity. And when we look at her methylation activity, you see it's pretty good. And then what about her progesterone metabolites? Well, this can help us as to whether do we give her oral progesterone if she's not going down that pathway, predominating down that 5-alpha pathway to help her with sleep, or is she favoring this 5-beta pathway? Well, looking here again, the postmenopausal range, there's your luteal range. There's your luteal range, and you see, you really can't tell. But what's interesting is that her DHEAS is low. Well, we saw that it was low before, but when you look at the DHE metabolites, this is why metabolites are so important. They are normal. In other words, her tissues are seeing adequate DHEA. So why is DHEAS low? think inflammation. Sulfation is decreased in an inflammatory state. So this is why comprehensive urine testing is key to optimum hormone health. And then what about her testosterone? Again, there's the optimum testosterone ranges. Well, it's low. And you see here her testosterone's low. Her epitestosterone's low. Her 5-alpha is on the lower end of the range. And her 5-alpha and beta androstenediol are, sort of in the middle. Now, with men, predominantly in Asian men and in some African American men, you can see what's called a UGT SNP, which makes testosterone interpretation in urine very difficult. You can also see it in women, but it's less so in women. And so what am I talking about? If you see a testosterone that's low, an epitestosterone that's okay, a 5-alpha that's low, and a 5-beta that's low, but the 5-alpha is okay, think UGT2B17. UGT2B17 conjugates testosterone, 5-alpha DHT, and 5-beta androstenediol. UGT2B7 conjugates epi and 5-alpha. So what would you see with a SNP? You would see T, DHT, and 5-beta low. You'd see epi-T and 5-alpha normal. And so if you see this, you just need to be aware that serum needs to be obtained. Now, I get serum all the time in men and women for testosterone, and I'm just aware of this. But I do look at metabolites and see how testosterone is being metabolized. So the bottom line is serum is the primary tool. Urine is necessary for comprehensiveness. And so we come back here. You see testosterone's low. 5-alpha is low. Epitestosterone's low. 5-alpha and beta are within range, and 5-alpha is at the lower end of range. So she has no evidence of a UGT SNP, okay? So just be aware, and as on her serum labs, testosterone is low. So now what are we gonna do? In all patients, you're gonna address lifestyle. And remember, it takes 45 to 60 days to make a change and see a result. Low intensity exercise, diet to stabilize blood sugar, fresh foods, high fiber, nuts and seeds, complex carbohydrates. Notice I didn't say no carbohydrates. Gluten and dairy free, especially in people who are inflamed. In this country, gluten and dairy are very inflammatory. 8 hours of restful sleep, practicing good sleep hygiene, no phones by the bed. Relaxation is very important and takes practice. Heart rate variability training, i.e. coherence training, meditation, yoga. Positive attitude is really important. Avoid social isolation and increase pleasurable activities. And when you're gonna use adaptogens, you can target them. A lot of them are general and you can use them, but here's just a list of adaptogens based on whether they have a high cortisol, a mixed cortisol, or low cortisol. And I treat adaptogens like prescription drugs. Start low, go slow, test, don't guess. And in Liz, because of her racing mind, I chose L-theanine and I chose rhodiola. I know her CAR is going to be elevated predominantly because you saw her urine cortisols, above the reference range. I could have chosen holy basil. She's inflamed. It's an immune modulator. It supports blood sugar. So there are lots of options. Get familiar with adaptogens. Use the ones that you're comfortable with. And so in Liz, gluten and dairy free, a Mediterranean style, low glycemic, lower carb eating plan, 30 to 35 grams of fiber, decrease running, increase resistance training, and address the gut. Probiotics, multivitamin, complex B vitamins, and methylfolate. And a product called Arterisol, which heals the glycocalyx layer, which is a sugar layer, which is key to endothelial health. 1 cap BID, fish oil, curcumin, magnesium taurate. She's anxious. Taurine is very calming, and continue vitamin D, but I added K2MK7 to shift calcium that's absorbed towards the bone and away from the gut. She chose a patch and vaginal E3, and E3 is 0.5 milligram per gram, 1 gram vaginally for 2 weeks, then twice a week, and then PRN. She chose oral progesterone, testosterone, 0.5 milligrams, and I gave her rhodiola, L-theanine, and I gave her DIM to kind of push that metabolism further down that 2-hydroxy and away from that 4-hydroxy. And after 3 months, follow-up testing with hormones, metabolites, cortisol, and then blood to look at FSH, see the effect, LH, serum hormone binding globulin, and of course, total testosterone. So what happened after 4 months? Well, she feels great. Her brain fog is gone. Her hot flashes and night sweats are gone, as is her vaginal dryness. Her energy levels are back to baseline. She's exercising less, and she no longer is anxious. She now gets 8 hours of restful sleep. She's exercising once a day, which was very, very hard for her. She needed a lot of support. She is an exercise addict. It was her way of de-stressing. But, you know, when you go too far the other way, it became a stressor. She's now running and doing strength training. She started taking a yoga class on the weekends with her husband and is enjoying it. And she takes 1 full day off a week from exercising. She's eating healthier, more vegetables, plant-based protein sources. And when she eats animal protein, it's all grass-fed and organic. She's getting about 20 to 25 grams of fiber a day. She's working on increasing that. And because she felt so bad, she's been compliant. And here are her follow-up labs. And we'll focus on her glycemic parameters. Look, they are much better. Look at her lipids. With just that, I didn't put her on statins. I didn't give her a ton of niacin. I gave her Atirasil to heal the glycocalyx and endothelial barrier. And we worked on her inflammation, her diet, her HPA axis. Look at all of this. It's excellent. Her CRP, I'd like it less than 1, but it takes time. And when you look at her hormones, her FSH has come down, her LH has come down, her serum hormone binding globulin is normal, her DHEAS has come up a little bit. I did not give her DHEA because her tissues were seeing adequate DHEA. I always could. I chose not to. Her total estradiol is 50. Remember, she has subclinical coronary disease, so she is one of those women who may benefit from a little higher serum level. And her total testosterone is 40 nanograms per deciliter. And here are her follow-up labs. Look at her cortisol. This is still high, so even though she says she's sleeping a restful 8 hours, she still has work to do there. The rest of her cortisol looks pretty good. And now when you look at her metabolites, they're becoming more balanced. Again, this takes time. Everybody may not do as well as Liz did. Some people's cortisone metabolites still may be high. Give it time. It may take 6 months. Everybody is different. And now when we look at her estrogen metabolism, this is where she was before. Her estradiol is 1.93. That's fine. Her estrone is low, and that's good. And from the vaginal E3, her estriol is high. 16-hydroxy has come up. 4-hydroxy has come down, and her 2-hydroxy has maintained really appropriate levels. And she is methylating well. Is she over methylating? No, but this needs to be watched. And when we look at her little estrogen metabolism ratio, still at 74%, this has come down to 8, and this has come up to 18%. When you look at her oral progesterone metabolite, she is going down that beta pathway. She's taking 200 milligrams. Can I increase that? Absolutely. Absolutely, if I need to. I may, or I may try something else. to get her to sleep more restfully, like she's still using her phone. She still watches TV till the last possible minute it's on in the bedroom. So we still have work to do on lifestyle things. Her testosterone has come up, and though her DHEAS is still on the lower side, her tissues are seeing adequate DHEA. And so here's her summary of what she has. And I give every patient a list like this, and so they know exactly what they're taking and why. She is also, by the way, now starting to do IV therapy twice a month, which includes vitamin C, methylated B vitamins, amino acids, glutathione. Again, I try and keep nutraceuticals to a minimum because patients get pill fatigue. She's feeling better, so she's going to be compliant. The question is when she feels so much better that she starts not being compliant. And that's why you need to follow patients on a regular basis. And that's why it's important to make sure that you do follow-up testing. And this is all the stuff we've already gone over. And just remember that there are no progesterone, serum urine, or salivary levels that accurately reflect the endometrium. You must balance estradiol's proliferative effects. And gels, transdermal testosterone, gels and creams, vaginal, labial testosterone, and T pellets, achieving serum levels at the high end, unless you're using pellets when it's above, all improve clinical outcomes. Again, start low, go slow. It's easier to increase than decrease them. I learned that the hard way. Ongoing restratification, which includes metabolomics, is a must for a successful hormone practice. And remember, women spend a third of their lives hormone insufficient or deficient. So it's important we get it right. And I leave you with test, don't guess. And why I used to use saliva, I will tell you, until I read the literature, until I dived into the literature, and I learned what I shared with you today. Why did I switch to the Dutch test? Because I get all of this. I get the biggest bang for my buck, and the patient's buck, really, about the patient's total hormonal balance. Not just sex hormones, overall hormonal balance. And this is something that I think you'll find helpful, where it's been updated. And as you can see, monitoring BHRT with lab testing, and it gives you the do's and the don'ts. And this is very, very helpful, especially if you're first starting out. And don't forget, if you have a hormone practice, don't forget about inflammation, gut immune brain, detoxification, thyroid, glycemic parameters, environmental exposure. You can do a lot with lifestyle. And as I tell everybody, enjoy the journey. It's not going to be easy, but it is definitely worth it. And I'll take questions, but let me remind you that if you become a provider, you will receive 50% off. And Dutch has an excellent clinical consultative team that will spend time with you, go over the test so that you get a better understanding of the test. Get started, you could call, you can email, or you can use the website. And I have for you additional references of a lot of the studies that I've cited for your perusing pleasure. And I guess I'll sit here, and Winter, I will take questions.
Great. Thank you, Dr. Saltiel. That was excellent. We have just a couple minutes left before our time is up, but I do have a couple good questions for you. I'm so sorry we won't be able to get to all of them. We have time, Lynn, the time we have left, but let's start with this one. Do you have a calculation when using E2 to progesterone balance in menopause hormone therapy?
Do I have, say that again, a ratio?
Yeah, a calculation.
Here's the deal. If you use, here's what the data tells you. If you use a 0.025 patch and you keep serum levels between 20 and 40, and your baseline progesterone is not greater than 10, you can probably get away with 100 milligrams. I typically start every woman at 200 milligrams. I want to get maximum endometrial protection. That's what the data says. Over time, depending on the patient, I may decrease it to 100 milligrams. Certainly, if I'm going above a 0.025 milligram patch, I definitely use 200 milligrams orally, or I go to vaginal progesterone 100 milligrams daily. Hopefully that answers the question.
I hope so too. Would you say that there's a window after menopause to make HRT effective? Like after a woman has gone through menopause, how many years do you have before they won't respond to HRT?
Every single woman will respond to HRT. Doesn't matter what age they are. But what the data shows is you get the most cardiovascular benefit within that first 5 to 10 years. But older women will respond. They will have a decrease in osteoporosis risk. They will have decreased fracture risk. You will decrease their vasomotor symptoms and vulvovaginal atrophy. So the bottom line is, in older women, I may use lower doses. They typically require lower doses, but I make sure that their endometrium, if somebody's naturally menopausal, is protected. So I do not hold back on prescribing menopausal hormone therapy for older women. I assess their cardiovascular risk. I assess their endometrial risk, their breast cancer risk. And then I slowly dose and I follow them meticulously. I can't stress enough how important it is to do follow-up testing. I typically do it after 3 months of, hormone therapy, and then I'll do it again at, 8 months, every 4 to 6 months, and then I'll do it at a year. And if they're stable, I do it twice a year. But you must do follow-up testing because risk changes.
Great, thank you. All right, I think we have time for just a couple more.
I'll stay on if we don't lose the webinar, if you want to go to 4:30.
Okay, maybe. What is your opinion on blood spot testing for monitoring patches and compound topicals?
No, there's no data to validate blood spot or saliva against the gold standard serum. So how do you know you are in the ranges that have been shown to improve vasomotor symptoms, vulvovaginal atrophy, and most importantly, bone mineral density? I have not seen blood spot validated against the gold standard, and what blood spot level is equivalent to that 20 to 40. Haven't seen it. Same thing with saliva. So how do you know, even though you're in their reference range, how do you know you're protecting bones, which is probably the most important thing? Women will tell you if their vasomotor symptoms are better. A GYN exam will tell you if vulvovaginal atrophy is improved, if you have increased superficial cells, less parabasal cells. They'll have less dyspareunia. But you can't do bone mineral density testing every 6 months to a year. So until those tests are validated, and I use those tests, until those tests are validated, how do you know that you are protecting a woman's bones? You don't. Okay.
Are there any studies showing the effectiveness of testosterone in treating fatigue and libido in menopausal females?
Yes. If you look at Becky Glazer's data, and if you look at the studies on hypoactive sexual desire disorder, which was what all the patch and the cream and the gel studies were done, they improved fatigue, they improved sexual function, including libido, and they definitely, when added to estradiol and progesterone, improved bone mineral density. So absolutely.
Great. Sorry, I'm trying to vet these a little bit here.
You're fine. You're fine.
Will correcting thyroid abnormalities first correct adrenal or sex hormone abnormalities in a perimenopausal woman, like DHEA, higher estrogen, higher cortisol?
Well, fixing thyroid will certainly impact the HPA axis, and the HPA axis more so impacts thyroid. And so what happens is the thyroid adapts. So if somebody has a high cortisol state, there's something called allostatic adaptation of the thyroid. What will happen is, because the thyroid uses energy to include glutathione, it is going to downregulate. The thyroid will adapt according to what happens to cortisol. So if cortisol is high, you may see a higher T3. If cortisol is low, you're going to see a low T3, T4, and TSH. So address the HPA axis. You may give them some thyroid, but don't start pounding them with thyroid hormone because they say, I'm not better, I'm not better, I'm not better. They're not going to get optimally better until their HPA axis is corrected. Here's a clinical pearl. If you see somebody who's got a low TSH or lowish normal, a lowish T3 and a lowish T4, it's not the thyroid, it's the HPA axis. So until you address the HPA axis, you're not going to optimize thyroid function. Just recognize that.
Okay, and is there a need to protect sexual partners when using vaginal forms of hormone therapy?
Yeah, that's a great question, and the answer is yes. If you are using vaginal, if you're in a heterosexual relationship and you're using vaginal estradiol, you want to put it on away from when you're potentially having sex. So a lot of women do it first thing in the morning because it no longer drips out. If you use it in a mucilage space, which is made for the vaginal mucosa, or if you're putting it on the labia and they go to work, it's gone by the time the evening comes. Same thing in a same-sex partner. You want to be able to protect your partner from exposure. And so do it about 8 to 12 hours away.
Okay, great. There's so many more coming in. I'm so sorry.
You're fine. You're fine. I'm fine. I wish I could see them to help you out.
I know there's so many. Would you use or prefer vaginal DHEA for GSM in a breast cancer survivor on an SERM over vaginal estrogen?
Yes. Yes. Passerone, which is the FDA approved vaginal DHEA, works wonderfully. So does vaginal testosterone. You know, what I would, and I've seen vaginal testosterone work really well. The thing is, you want to check with the oncologist. And if you're using low enough doses of testosterone and they're not aromatizing, you're blocking aromatization, they should do just fine. And in fact, women do very well with testosterone in breast cancer survivors. In fact, they do well with pellets. Becky Glazer has published on breast cancer survivors and pellet use. So testosterone is typically my go-to.
Okay. If a patient is complaining that oral progesterone and transdermal progesterone are causing her to be sleepy and not really feeling like herself, should this practitioner try to get her on the vaginal progesterone?
Yes, first of all, no transdermal progesterone, period. If she's a premenopausal woman and you're trying to improve luteal, the luteal progesterone levels for pregnancy, not a lot of data on transdermal progesterone. Vaginal progesterone is the way to go. In postmenopausal women, as I said, don't use transdermal progesterone. I would use vaginal progesterone in that woman. I would check estrogen metabolism. I would do a Dutch complete so you can see how she's metabolizing progesterone and she may be going down that alpha pathway. And in somebody like that, I absolutely would put her on 100 milligrams of vaginal progesterone. She will do very, very well.
Thank you. In cases of low sex hormone in menopausal women, when is the time when you decide to just use herbal or supplements to balance hormones and symptoms? And when do you decide to use hormone therapies?
Yeah, you're going to get very different answers on this. I typically will, in a postmenopausal woman, if she's recently menopausal and still has estrogen and testosterone and some progesterone, I will use nutraceuticals. Now, you're not going to get nutraceuticals to really increase estradiol. You'll get nutraceuticals to relieve her symptoms. So you're not going to get bone protection with nutraceuticals. So if her estradiol is above 20, I'll use nutraceuticals for symptomatic relief. I'll use chasteberry for progesterone. There's not really a whole lot of that I've seen patients getting really good responses for testosterone. If I'm worried about bone mineral density and estradiol levels are below that 20, and like in Liz, she has no hormones, I go right to hormone therapy. My goal is to improve clinical outcomes, which is, in this case, is prevent she already is osteopenic, is to prevent osteoporosis and fractures. And there are no nutraceuticals that protect the bones. So just keep that in mind. And so I look at baseline levels.
Okay, great. Thank you. This is going to be our last one, and I think it's kind of a fun one to end on. Dr. Saltiel, what is your favorite way to assess cardiovascular risk?
All right. So if we're talking about somebody who's got no risk factors on a history, I will base, and they're young, I basically start with an advanced lipid profile. I really don't do just, the traditional screening lipids anymore. Partially because they don't tell me about LDL particle number. They don't tell me about LPPLA2 and vascular inflammation. They don't tell me about any of those things. If somebody is in the age where they can potentially have coronary disease, meaning anybody above 30, as far as I'm concerned, they have any risk factors like they're insulin resistant, they're got elevated fasting blood sugar, they're stressed, HPA axis dysfunction, they're going to have endothelial dysfunction. So just know, taking a history, you can tell if somebody's going to have endothelial dysfunction. In those patients, I do an advanced lipid profile, and I'll start with a CIMT. Do I do a coronary calcium scan on every person? I wind up doing it, but I do it once. And then when do I repeat it? If something dramatically changes. I give everybody arterisol because it heals the endothelium and that glycocalyx layer, which is what causes the endothelium to be permeable, where macrophages and LDL get oxidized. Macrophages get there, they eat them up, and they become foam cells, and you get atherosclerotic plaque developing. So to answer your question, I risk stratify everybody, even teenagers, because more and more there are stressors, there's hypertension in young individuals, their diets are poor. So in all of those people, they at least get an advanced lipid profile. And then depending on what that looks like and their degree of inflammation, their CRP, and the advanced lipid profile, I'll then move on to a CIMT. If they're really young and their pretest probability of coronary disease is low, I probably don't do a coronary artery calcium scan. If they're in that over 30, then I may do a coronary calcium scan. And just so you know, hormone levels in women dramatically change during the menopausal transition, which is, when risk starts to increase, when endothelial dysfunction is at its maximum. So it's during those changes where you will see endothelial dysfunction, which is the first step in the atherosclerotic process. When we're talking about men with insulin resistance, men who are stressed, men with low testosterone, same thing. They get endothelial dysfunction. And just so you know, cortisol, elevated cortisol, low cortisol, causes havoc on the immune system. Inflammatory cytokines increase. If you have any degree of inflammation, by definition, you have endothelial dysfunction. If you have a permeable gut, you have endothelial dysfunction. You have permeable blood vessels. If you have thyroid antibodies, poor man's test, meaning that endotoxin gets through, you have endothelial dysfunction. And then I do that workup, which is advanced lipids, which is CIMT, and may include a coronary artery calcium scan. They get put on artericell in addition to other things. Hopefully
All right. Well,
question.
I think that's all the time we have for today. Thank you again, Dr. Saltiel, for this excellent lecture and case study. And thank you to everyone for joining today's Webinar Wednesday. We hope you'll join us all again next month.
Bye, everybody. Have a good holiday. I think Memorial Day is coming. Memorial Day is coming up, as is July 4th. So, guys, have a great holiday season. And I look forward to chatting with you all again. Have a great day. Bye.